Hi everyone. So today we're doing Pathoma chapter 6, like the high yield takeaways. This has actually been like my most requested session like in years past for this block. Um, so I hope it's helpful. All right. So first order of business is basically discussing the difference between leukemia and lymphoma. I know like on paper it seems really obvious, but then you're thinking about it and you're like, well, aren't the lymphocytes in the blood versus, So we're gonna go into it like a little bit into like just kind of like explain it more like clinically. So a leukemia, there's many different types of leukemias. We're gonna go through all of them today. Well, all of them that are in Pathoma, chapter 6 Pathoma. Leukemias are also a cancer of blood. That's like literally what emia stands for. It stands for the blood, like anemia, no blood. Well, there's just no hemoglobin, no oxygen in the blood. But that's kind of where that root comes from. These cancers for leukemias arise from stem cells of the bone marrow. So all of the cancerous cells are coming from cancer cells in the bone marrow. Okay. They usually metastasize, and leukemias also metastasize via the lymph node. So it's in the blood, so it can go everywhere. But if it metastasizes to organs or anything, it's doing so via the lymph nodes. Versus lymphomas, there's only two types. There's Hodgkin's lymphoma and non-Hodgkin's. That's it. This is a cancer of your lymph nodes, right? So lymphoma, of course, but that means it's going to arise from cells that are in the lymph node already. So it's already, if you can think back to immunology, they're already in those secondary like tissues. So remember the bone marrow is your primary lymphoid tissue, and then it can kind of leave and enter the blood and then go to the lymph nodes and whatnot. So this is like kind of when we talk about the lymphomas, a lot of the times it's going to be those cells that are already out there in the lymph nodes. They can metastasize anywhere. I mean, once cancer, I'm sure you guys even know this, even without doing any of chapter 6 of Pathoma, but once a cancer is in the lymph nodes, it can go anywhere. It can even go back to the bone marrow. But both are considered hematologic neoplasm. So I know this word hematologic makes you think blood, but both of these are considered hematologic neoplasm. It's just where is the cancerous cell? Is it in the blood? Did it arise in the bone marrow, or did it arise in the lymph nodes? So hematologic neoplasms, these are neoplasms in the blood and the bone marrow, and it results when cells divide more than they should, or they do not die when they should. So it's like they have a lack of apoptosis, so they're not dying when like they're getting signals telling it to die, or they're just dividing way more. They have a lot more ability to replicate than they should. And then from here, if it's so all hematologic neoplasms are malignant. There's no non-malignant hematologic neoplasms. But you can further differentiate that malignancy is it myeloproliferative or is it lymphoproliferative? Myeloproliferative versus lymphoproliferative kind of gets into the differentiation scheme of stem cells. So we're going to go into it again. It was on your syllabus, so we'll go into it into more detail than I did in the anemias session. But a myeloproliferative hematologic neoplasm is a malignant disease of any of the precursors of your red blood cells, your granulocytes, and your platelets. Again, this can include your lymphomas and your leukemias. A lymphoproliferative hematologic neoplasm is a malignant disease of your lymphoid cells, so your B and T cells, and you'll see, but like precursors of the lymphoid stem cells that turn into your reticuloendothelial system cells, such as monocytes. And then finally, Dr. Sitar goes into talking about the difference of acute versus chronic, and this is very helpful in terms of the names of the cancers. So if you have an acute cancer, the onset is going to be very, very sudden. So it's going to be like the patient wakes up one morning and then they're not feeling well, like immediately. Versus a chronic hematologic neoplasm, the onset is more insidious. It kind of creeps up over time. It's like maybe they haven't been feeling well for several days, several weeks, things of that nature. Similarly, the cell type of an acute cancer is going to be blasts. Okay, so these are immature cells, and I think that these two go together. So if like an acute cancer, it's sudden, it's a blast cell, like it just sounds very like nah. Versus a chronic, it's going to be more insidious. It's slower, it's more mature, it's taking its time, things like that. But and then the cell type more commonly seen in these chronic hematologic neoplasms are going to be more mature versus immature. You still can see immature cells in your chronic cancers. People do get confused. So if you have like chronic lymphocytic leukemia, you can still see some immature cells in that, but a lot of the times it's going to be the more mature versions. And especially for your like exams and for boards and stuff, they're going to stick to this scheme. All right, so we're going to start with the leukemias. So this is, you should definitely know this for your exam. But here's your hematologic stem cell. Yeah. So here's a blood stem cell, and then from here you can either go into a myeloid stem cell or a lymphoid stem cell. A myeloid stem cell, as you can see, goes into your red blood cells. So we talked about this with the anemias whenever we did that one. But just as a reminder, once you have a myeloid stem cell, it can differentiate into a pronormoblast, a basophilic normoblast, a polychromatic normoblast, orthochromatic normoblast, polychromatic erythrocyte, and then finally your red blood cell or your erythrocyte. Myeloid stem cells can also turn into megakaryocytes, and remember, just fraction off, those are your platelets. Myeloid stem cells can also turn into immature monocytes and then eventually turn into monocytes. I will say that a lot of people have absolutely no idea where like monocytes and dendritic cells, that whole like maturation scheme is still very much debated in the science world. I work with macrophages in my lab, and whenever that question comes up, it's always like, oh, I have to go through like millions of research articles, because it's like no one truly knows like the true differentiation scheme of monocytes. It's like a question mark from immature monocyte to monocyte. They're like, we don't really know what happens. They know dendritic cells pops up somewhere, but regardless. And then we have like the your granulocyte precursors. So now we have our myeloblast. A myeloblast is all of your granulocyte precursor cell. So it can go into an immature basophil and then eventually a basophil. It can go into an immature eosinophil and then an eosinophil. And then it can go down this scheme down to a neutrophil. Definitely know this one just because it's clinically relevant. Some of the cancer names that we're going to go over today have names based on what stage of development the cancer arises from. So for example, from this myeloblast, we have a promyelocyte, then we have a myelocyte, then a metamyelocyte, then a band, and then a neutrophil. On the other side, from the blood stem cells, then we have lymphoid stem cells. Lymphoid stem cells will develop into lymphoblasts, and then lymphoblasts eventually will go into your B cells, your T cells, and then your NK cells. This isn't exactly like truly 100% correct. It's a very simplified drawing. I know we talked a little bit in immuno that natural killer cells actually derive from T cells. That's true. It's just, this is a very simplified drawing. All I'm showing is like the lymphoblasts give rise to basically your B and T cells. Those are going to be the most relevant in terms of like the cancers we're going to be discussing. The lymphoproliferative, the cancers of the blood that arise from these types of cells in the blood, in the bone, because we're still in the bone marrow here. Okay. All right. So this is again, like I said, this is a simplified scheme. I kind of broke it up from the last slide, but we have this blood stem cell, a myeloid stem cell, a lymphoid stem cell. Myeloid stem cell, we have our red blood cells, platelets, your myeloblast, and then it gives rise to all of your granulocytes. Lymphoid stem cell gives rise to your lymphoblasts. In the bone marrow, it gives rise to your B cells. In the thymus, these primary lymphoid organ, that's where these lymphoblasts are located. It's going to give rise to your T cells. And then also NK cells are in there somewhere. And as a reminder, B cells also develop into plasma cells. We're going to talk about multiple myeloma briefly today. So plasma cells make a comeback. And then as a very basic reminder, these are considered your white blood cells, then you have your platelets, and then you have your red blood cells. So I would, if you're ever kind of lost doing questions or trying to think of this scheme in your head, try and envision this. Like try to envision what these stem cells are, the names of those stem cells, like understanding that myeloblast, I know this is, again, very simplified compared to the last slide, but understanding that the myeloblast gives rise to all these different cell types and then eventually your neutrophil, and additionally your other two granulocytes, it's going to help you with a lot of the cancers. Okay. So this was kind of my scheme of, again, going through tutoring sessions over the past several years, knowing that what people kind of get tripped up on. So if we're back to this whole idea of myeloproliferative versus lymphoproliferative, for myeloproliferative, these are cancers of your myeloid stem cell lineage, right? So what are all the cells in the myeloid stem cell? They were all on the last slide, right? So from this myeloid stem cell, what are all the cells that can come from this? You can have myeloblasts come from this. You can have red blood cells coming from this. These myeloblasts can turn into granulocytes, but granulocytes are basically coming from your myeloid stem cells, just, indirectly further down the line. And then your platelets are coming from your myeloid stem cells. So these are your myeloproliferative leukemias. They are going to be leukemias, like cancers of the blood, arising from the myeloid stem cells, okay? Okay. From here, another thing that I kind of point out to people, and I think it clicks for a lot of people, the cell type that the cancer is arising from. So let's say it's a myeloblast. If it's a blast, you're gonna have it's gonna be an acute cancer. Okay? So for example, because again, blasts, remember that's why Satara went through acute versus chronic. Cancer, so usually your acute cells, they're sudden, and the blasts are the ones that take over. So if you have a cancer of a myeloblast, you can assume acute's going to be in the name, sure, and then you have your myeloid leukemia, okay? How about if we have a cancer of the granulocytes? So remember, granulocytes are like down the line of your myeloblast, right? So your myeloblasts are the stem cells. Let me go to this one. Your myeloblasts are the stem cells, and then eventually it gives rise to all your granulocytes down here, right? So if we have cytes here, we don't have granuloblasts, right? These are granulocytes. So again, cytes, this tells me these are mature cells. So this is mature. So already in the name, I know chronic's going to be in the name, okay? So I have a chronic myeloid, because it's myeloid, it's from the myeloid lineage, leukemia, because we're still talking about these leukemias. Good so far? So if the cancerous cell is a blast, it's likely going to be an acute blastic cancer. If the cancerous cell is a cyte, this tells me it's mature. That means it's likely going to be a chronic cancer, non-blastic cancer. You can still see blasts. Like I said, you still can see blasts. It's just overwhelmingly the cancerous cell is going to be the mature cell. So that's what you're going to see overwhelmingly. And then other things you can kind of see, they aren't technically considered cancers, but they call them myeloproliferative diseases, and it's exactly in the name. So if you break up the name, myeloproliferative, so myelo because it's myeloid derived, proliferative diseases, it's essentially saying this is a cancer, but you can't, for whatever reason, they don't call a red blood, like myeloproliferative diseases of the red blood cells and platelets, they don't call them cancers, but they're cancers. It's just cancer. They proliferate a lot, right? So that's just what they're calling them. So if you have basically a cancer of your red blood cell, that's your polycythemia vera. We'll talk about that. And then if you have a cancer of your platelets, that's called essential thrombocytosis. I've also seen essential thrombocythemia, same thing. On the other side, if we have a lymphoproliferative hematologic neoplasm, that tells me that our leukemia is going to arise from one of these lymphoid stems. So it's going to be arising from one of the branches of the lymphoid stem cell lineage. So if we look at it, we can have lymphoblasts, we can have the actual B and T cells, again, located in the blood. You can have your lymphomas, which we'll talk about later. And then your plasma cells can actually itself turn cancerous. So same thing as the myeloproliferative diseases. If it's a lymphoblast that is the cancerous cell, this is telling me it's a really immature cell, it's acute, it's blastic, right? So my name here is going to be an acute lymphoblastic leukemia because it's a lymphoblast, it's acute. If I have my B and my T cells that are already out in the peripheral blood, they're already out there circulating, they haven't gotten to the lymph nodes yet, but they're out there, that's going to be your, so these are mature cells, these are your B and T cells that have left the primary lymphoid tissue. This is going to be your chronic lymphocytic leukemias. So nothing about blasts in the name and nothing about acute in the name. Like I said, we'll talk about lymphomas later, but these are going to be ones that arise directly from the lymph node. So these are usually going to be those cancer types, like your B and T cells that are already activated. They go to, a lymph node or some secondary lymphoid tissue, and then they become cancerous. But we'll talk about lymphomas at the end. And then lastly, your plasma cells can actually turn cancerous, and that's going to be, they don't call it cancer again. They call them plasma cell dyscrasias. again, it's a cancer. But primarily we're going to talk about multiple myeloma. That's the most common one. And you actually probably either know someone that has multiple myeloma or will see it because it is more common than some of these other ones. All right, so kind of like now just taking out the words. Taking out the figures and now just so you can see it in words. You think about this: hematologic neoplasm. Is it myeloproliferative? Is it lymphoproliferative? What is the stem cell lineage that is cancerous? Let's say it's myeloproliferative. Okay, is it acute or is it chronic? Are these blastic cells or are these mature cells? If it's blastic cells, that means it's going to be acute, and that's your acute myeloid leukemia. If it's chronic, you're going to have your more mature cells. You're going to have your chronic myeloid leukemia, your polycythemia vera. This is going to be your red cell cancer, your essential thrombocythemia. I even interchanged it. So essential thrombocythemia or essential thrombocytosis, I think. Yeah, either one's fine. And then you can also have something called primary myelofibrosis. I can't remember if it's on here. I don't think Sitar talks about it. I forget. I don't know why it's not on the previous slide. But this is also something that comes up. It's also a cancer of the bone marrow. And then lymphoproliferative, again, is it an acute cancer or is it a chronic cancer? If it's an acute cancer, that's going to be your blastic, right? So ALL, this is your acute lymphoblastic leukemia. Chronic, remember, this is going to be more of your mature cells. It's going to be slower over time. So this is your chronic lymphocytic leukemia. And I put the 2 stars here because this is the most common leukemia overall. And like I always try to tell people when you're studying, especially when you're getting into the boards mindset, keep an eye on the things that are most common because that's what you're going to be actually seeing as a doctor. Some other types of chronic lymphoproliferative hematologic neoplasms are hairy cell leukemia, which is not on the previous slide, but I think we talk about that one. Lymphomas, which again, we're going to talk about. These are pretty much the same as the this is pretty much the same as the leukemias. It's just where the B and T cells are at the time of the cancer that the cancer developed. And then your plasma cell dyscrasias, including your multiple myeloma. And this organization system, I don't want to be remiss and say because there's a bunch of different ways you can classify it. I think this is the best way. And like I've said in previous PowerPoints, I was literally working in a hematology lab. I'm certified as a hematologist technically. I think it runs up next year though, but whatever. But regardless, I had to take the boards for it. And there's many classification systems of this stuff. So if you see another chart online, it's probably also right. This is what the this is the World Health Organization's classification system. I think theirs is the most intuitive to understand, at least. All right, and then kind of a throwback to immuno, but it was on your study syllabus, study guide, whatever. But B and T cell development. So as a reminder, because these are going to be good markers for cancers, tells you how immature or mature is the cancer cell. They're not going to tell you oh, this is an immature B cell. They're going to give you markers, and then you can be oh, that's an immature marker versus a mature marker. That's a B cell marker versus a T cell marker. Because a lot of the times, remember, when you're looking at peripheral blood smears, you can't tell if it's a B cell or a T cell. You just know it's a lymphocyte, right? When you're just doing smears, looking at smears. So what they do tell you is they give you the CD marker, and you have to be okay, this is a B cell ALL, or no, this is a T cell ALL, or something like that. So here is your stem cell. So we have CD34. This is your marker of immaturity. And then another marker of immaturity is TDT. So TDT is going to be the immature cells DNA polymerase, and this is in both B and T cells. So they're very immature. They're very immature if they still have TDT. So they'll actually tell you if you're doing vignettes, this cell is TDT positive, or this cell is TDT negative. So if they tell you a cell is TDT positive, you know it's an immature cell. You don't know if it's a B cell or a T cell, but you know it's it's one of these immature cells. Then you start seeing some B cell specific markers start to arise, CD10. You see some T cell markers start to arise, CD2, CD3, CD5, CD7. And then from your immature B cell, you'll eventually, you don't have to remember that whole scheme like you had to memorize for immuno, the immature pre-B cell, pro-B cell, blah, blah, blah. Just I would know, CD19, CD20, CD21. These are B cell markers. And the 2, 3, 4, 5, 7, these are T cell markers. And I put this on here because here's CD4, here's CD8. Again, it depends on, is it a cytotoxic T cell or is it helper T cell? This is also another chart. I actually use this to study for my hematology boards back in like whenever I took those. These are other markers of lineage. So these are lineage markers. So we talked about, CD3, this is a T cell marker, CD5 is a T cell marker, CD7 is a T cell marker, 10, 19, 20, those are B cell markers. Sometimes they'll give you like granulocyte, monocyte markers. CD14 actually comes up a lot. I think I talked about CD14 in the immuno sessions. This is going to be your LPS receptor. So this is TLR4. So I actually study this in my lab right now in the PhD. I look at CD14 and I work with macrophages. So macrophages are basically monocytes. So this is I feel like the most relevant one. But if you know this, sometimes boards throws you random CD markers because they know people aren't like studying all of them. But it might help you out. Who knows? But then from here, there's other ones too. So like megakaryocytes. So megakaryocytes, they have the markers for, 2B3A, 1B, and whatnot. So they're there. And then again, I would definitely know your immature cell markers, which is like CD34, TDT, CD117. I didn't really mention, but that's, also one. So this is just for you. Maybe if you're doing UWorld questions and it does actually pop up like CD markers, you can kind of like annotate this page. Okay, so before we kind of dive into the actual cancers and whatnot, so this is like my advice for things to keep in mind with vignettes, especially with the cancers. So chapter 6 material, vignettes. Cancer symptoms, super nonspecific, especially lymphomas. Lymphomas sounds like every cold that you've ever seen someone have. Okay, they're so nonspecific. They don't help you at all. So if you're looking at symptoms, like, when we were talking about like with the primary and secondary hemostasis, I'm like, okay, these symptoms sound like a primary hemostasis disorder. These symptoms sound like a secondary hemostasis disorder. You can't do that with this. I don't even care if it comes up a million times for like CLL. It's always in the vignette for CLL. It doesn't matter because you're going to get one on boards. It's not going to be in there and it's going to throw you off. Symptoms for vignettes about cancers are very, very nonspecific. There's certain ones, there's like unique things. That's what you need to learn because that's what they'll always give you. Okay, but I wanted to mention it because some people do get tripped up with some of the symptoms, and they're like, "That's got to be, B cell ALL," and I'm like, "No, that can be any cancer." Okay, so for example, a blastic leukemia. So this is just like a fact about blastic leukemias. I did kind of talk about this in the anemia session, but if you have a blastic leukemia, the patient's going to present with pancytopenia. This is usually because this cancerous blast is just replicating like crazy. So it takes up all the room in the bone marrow, and then there's no room for any other cell to develop. That's why you can't get more white cells, you can't get more red cells, you can't get platelets. So you have pancytopenia usually in any blastic cancer. Any blastic cancer that you come into contact with can present with pancytopenia. But you can't use pancytopenia to diagnose a cancer because that can happen in any of the blastic cancers, okay? You can use the patient's age to rule certain ones out, but it's not always good and it can get you in trouble sometimes. Like I said with the primary versus secondary hemostasis ones too, when we go through vignettes, age should always be like a last resort, like a Hail Mary throw. Like, let me look at the patient's age, just in terms of like immunology stuff. But for example, ALL is a childhood cancer, but it is possible that it can affect adults. And you know what? UWorld's going to give you an adult with ALL, and you're going to be like, wow, I will never see an adult with ALL while I'm practicing. Okay, it's rare, it's possible, but it is possible. CLL, that's usually an adult cancer, like in your 50s and 60s. They might give you a child with CLL just for fun. But if you're just like, I'm between ALL and CLL and it's a young kid, I would pick ALL, okay? That's just kind of my 2 cents with using age. And then finally, they're going to give you a unique feature. If you don't believe me, do the vignettes at the end. They always give you something unique. So they might show you our rods. They might give you a translocation, show you a Reed-Sternberg cell, give you a CD mark. They're going to give you something. That's what you need to memorize for chapter 6, okay? So I know there's a lot of information in chapter 6, but they're always going to give you those unique features. That's where your attention should be focusing. And we're going to go through, I even gave you guys like 1 to 2 slide, like high yields. That's the whole point of this PowerPoint, right? So I gave you what you should be memorizing for these things, not only just for your exam, but also for boards. So first, we're going to talk about just leukemia in general. Kind of that's what Dr. Sittard does. He mentions that it's an abnormal neoplastic proliferation of your hematopoietic stem cells. Again, we're in the bone marrow. Predominantly your white blood cells, but again, you can have your chronic cancers. Those are out in the blood. So the hematopoietic stem cells, predominantly white blood cells in the bone marrow and in the blood. Again, it depends on, is it a blastic cancer or is it a non-blastic, acidic, so to speak, cancer. Causes for leukemias, basic stuff that people say causes cancer, right? So ionizing radiation or exposure to benzenes. Genetic causes, again, they don't really understand it, but they think there is a genetic component. Viral infections. So viral infections, a lot of the times cancers are triggered by viral infections. So that can be another cause. Non-specific clinical symptoms, this is going to be, you can see any of these in a vignette about anyone with cancer. They call them B symptoms, and I actually think it's really funny that they call them B symptoms because they're saying these are not A. It's like, you know how it's like A, like plan A, then plan B? I like that they're basically like, these are B symptoms. They're not like the most important. They're just like, they're after A. It's like a plan B type thing. So plan A is going to be your unique features. Plan B is going to be like these B symptoms. They're just not as important. So like fatigue, fever, bleeding because of the pancytopenia, right? So you can have thrombocytopenia from that, headaches, bone pain because of the bone marrow involvement, various things like that, okay? These are not things to be looking out for in vignettes. Here's this scheme again, and I want to kind of start with the blastic cell lines. So your myeloblast and your lymphoblast. I want to start there and then work our way to more of the mature cells. So your myeloproliferative leukemias, as a reminder, these are going to be cancers forming from any cell that derives, directly or indirectly, from a myeloid stem cell. So if the cancer derives from a myeloblast, that's your acute myeloid leukemia, AML. If the cancer is arising from granulocytes, these are mature cells, they're out in the blood already. This is your chronic myeloid leukemia, CML. If it's a cancer of the red blood cells, it's not called a cancer, it's called a myeloproliferative disease. It's the same thing. Polycythemia vera, platelets, it's a myeloproliferative disease called essential thrombocytosis or essential thrombocythemia. So starting with acute myeloid leukemia or AML, again, we know it's acute, so we know we're looking for blasts. So this is characterized by myeloblasts in the bone marrow. This is what a blast looks like. It's a big cell. I can't remember if I talked about blasts at all with the peripheral blood smear session, because you really shouldn't see these out in the peripheral blood smear, right? These are out in the bone. These are still in the bone marrow. But regardless, if they show you a picture, blasts, their nuclei are huge. So this nuclei is just massive. And the cytoplasm, they call it like glassy cytoplasm. It's kind of like when I was describing monocytes, I said they had like glassy cytoplasm. It's the same thing here, but it's a massive cell. And the nucleus is really big. If you weren't like thinking these were blasts, you might think like, oh, this kind of looks like it could be a monocyte, right? It is kind of very similar to a monocyte. It's a lot bigger than a monocyte. A monocyte should not be. Monocyte should be, remember, white blood cells should be the size of red blood cells. So if these are the red blood cells in the slide, your monocyte might be like that. It might be like a little bit bigger. This is massive. This is like almost like, I don't even know, like 4 times the size of a normal monocyte. So these are really, really massively big cells. You might only be able to see like 30 of these cells on one slide versus like 60 or 70. That doesn't make sense mathematically, but regardless, they're very big. If I'm going to show you like a smear with just full of blasts and it's just like, whoa, like that looks weird. Those aren't all monocytes. Those look odd. Okay. So they're characterized by myeloblasts in the bone marrow. Myeloblasts are going to stain positive with myeloperoxidase. So MPO stains them, and you see the presence of our rods. So here's something that you need to be looking out for AML. You're going to see our rods. Basically what our rods are these are myeloblasts, right? So remember at the end of the day, myeloblasts eventually turn into granulocytes, right? They turn into your basophils, your eosinophils, and your neutrophils. All of those have granules. That's why they're granulocytes. And the granules have to start developing in the myeloblasts. That's why it gives rise to the granulocytes, all of them, and not just a specific type, just all the granulocytes. So basically what these hour rods are they're like crystallized granules that haven't been able to start to develop yet into like, okay, what type of granule should I be? Should I be, myeloperoxidase? Should I be, I don't even remember that, major basic protein? Like what type of granule should I be? Heparin, histamine, like what should I be? So that's why they just kind of crystallize. And then if you stain with MPO, myeloperoxidase, they actually pick up the stain. And then there's your hour rod. So they're always going to be in the cytoplasm. So you see them here. They're always going to be in the cytoplasm. And yeah. So the subtypes of AML is going to be based on the type of subsequent cell after a myeloblast. So if I go back to this slide. So if I have like a promyelocyte that's going to turn cancerous, that's a subtype of AML. And etc. So like a myelocyte turns cancer. It's like whatever, which you'll see in a second. But the subtypes here are going to be acute promyelocytic leukemia, acute monocytic leukemia, and then acute megakaryoblastic leukemia. And I know it doesn't really follow the same scheme here with acute and then blastic. But the reason for that is because these are subtypes of acute myeloid leukemia, which the cell type that's cancerous there is a blast. But if you look on this scheme, it's a blast, but then it switches over to site. So they just kind of named it. They just kind of named it based on the name of the cell that's cancerous, which I know, again, it doesn't really help with the advice I gave you, the little trick I gave you, but it can just kind of remember that these are all subtypes of AML, which is a blastic cancer. Okay. So acute promyelocytic leukemia, that's APL, acute monocytic leukemia, and then acute megakaryoblastic leukemia. So this one kind of broke the scheme, but it's all right. And all of these are going to have hour rods, all right? Cool. All right, so here's acute promyelocytic leukemia, or APL. This is a subtype of acute myeloid leukemia. You need to know every single translocation. If you see a translocation on the slide, you need to know it. And we'll talk about translocations when I talk about the Philly chromosome, I think I talk about it for CML. We'll talk about translocations, but just know that genetically, this is a translocation. It's a translocation of chromosome 15 with chromosome 17. So T15, 17. You will get asked, you are going to get asked translocations. That I can almost promise you. So what does this do? So what does this translocation do? Like, why do I care that a part of chromosome 15 and a part of chromosome 17 like swaps places? Like, what does that do? The result there is that the retinoic acid receptor, or RAR, is going to be disrupted. So the development of retinoic acid. Okay. Retinoic acid is also a derivative of vitamin A. So you're basically blocking the receptor for vitamin A. Okay. Vitamin A is, again, I don't know when I would have talked with you guys about vitamin A, but vitamin A is very important for development and just growth and maturity and development. So if you don't if these cells, they don't have a receptor for vitamin A, they can't take vitamin A in. Well, they can't get vitamin A just naturally with the surrounding environment. They can't uptake vitamin A and they can't grow. The growth is stunted. So maturation of the cell is blocked. And that's why it kind of stops here, right here. Maturation from all the way down to a neutrophil stops here because there's no more maturation that can occur because the retinoic acid receptor is disrupted. So promyeloblasts accumulate, and then that's where your cancer that's where cancer comes from. This cancer comes from. You have increased risk of DIC. I know we haven't talked that much about DIC yet. We're going to talk about it. I have a whole little slides on it for later, I think next week. But there's an increased risk of DIC, disseminated intravascular coagulation. And the reason why is these granules are actually acting as a trigger for, massive clotting, massive fibrinolizing for whatever reason. So I've gotten asked this on boards before. I've gotten asked about, they actually they told me the patient had this cancer, but then the vignette question was about DIC, and I had to recognize that they were undergoing DIC. And it was funny because they asked me the treatment for the patient's condition, and they wanted me to pick the treatment for APL. They wanted me to, but what the patient was undergoing right now was DIC. So I had to treat DIC. So just something to pay attention to. Out rods are going to be seen. A lot of these you're going to see out rods because that's the accumulation of the granules. So in this image, these little slashes everywhere. These are out rods. So this is the APL one. It's harder to see out rods because there's so many granules that it like almost obstructs all these out rods, but they're here. And the ones that you see like in the nucleus, they're just overlaid on top of the nucleus. They're not actually in the nucleus. And then how do you treat this? So if the retinoic acid receptor is disrupted and it can't uptake like normal vitamin A, you can give something called ATRA, all trans retinoic acid. This is a derivative of your normal vitamin A that the promyelocyte can actually uptake without RAR. And then you're basically forcing maturation. And you can actually cure this cancer, which is so wild. Like you can cure this cancer by just making this cancerous cell just like mature. And then it'll go all the way down to a granulocyte and it's fine. Because the reason that this cancer is bad is that the promyelocytes, whatever, they accumulate. And then it's, you can get all the, you're going to get, pancytopenia. You're going to get all sorts of issues here. You can get DIC. All right, next one's your acute monocytic leukemia. This one's like not super important to be honest, but we're going to talk about it because Dr. Sitar did. So this is another AML subtype where you're going to have monoblasts proliferating. So proliferating, that's not a word. Whatever. They are undergoing maturation. They're undergoing growth, not maturation. But remember, like I said, they don't really understand the immature monocyte scheme down to like a monocyte. They might understand it, but like no, it's not super important. So in this development to a monocyte, you do get monoblasts at some point, and then, it eventually turns into your monocyte. But monocytes there's actually no out rods here because think about it, monocytes don't have granules. And what I say out rods are granules that have basically crystallized. Okay. And the main thing to know with acute monocytic leukemia is that this is a symptom that's unique, is it likes to infiltrate the gums of its patients. So if they tell you, this patient has cancer, looks like it's a blast, and there's no out rods seen, but, it's the gums are kind of destroyed, I would think acute monocytic leukemia kind of early on. And then acute megakaryocytic leukemia, that's going to be a cancer of your megakaryocytes. So again, from your acute, so I know I keep going back to this slide, but on the way from a myeloid stem cell down to a megakaryocyte, there's probably some sort of maturation that's occurring here. And one of the steps in that maturation scheme is likely that you get a megakaryoblast. Megakaryocytes, they don't have granules either. So remember that you're probably not going to see out rods. And look at that, you have no out rods. And the main takeaway with this is that there's two of these leukemias that are associated with Down syndrome, and they get asked. I actually got asked this on my Comlex, and I like had a panic moment because I'm like, oh my god, which one's before and which one's after age 5? I was like, oh no. But acute megakaryo, I actually don't remember what I put. I think I blacked out. But acute megakaryocytic leukemia is associated with Down syndrome before the age of 5. Okay. So ALL, when we talk about ALL, you'll see it's associated with Down syndrome after the age of 5. So just don't get that confused because it has been asked before versus after. But this one is associated, and this means like if you have this cancer, it's like associated that you're going to also get Down syndrome before you even turn 5 years old. ALL, you might have ALL as like a 4-year-old, and then you'll get Down syndrome like at 7 or 8, so after the age of 5. All right, next is CML. So CML is chronic myeloid leukemia. So chronic, again, we know we're going to be kind of dealing with more mature cells here. This is a neoplastic proliferation of granulocytes, right? So your mature cells. So this is just a straight up CBC. It's not a special stain. It's not the bone marrow. CBC. Look how many basophils are here. So I know that this is a cancer, the granulocytes, but look at all these basophils. So this is basophil, this is basophil, this is basophil. Remember, like I said, when we were doing the peripheral blood smear stuff, you should only see like one, if that, in all 10 slide views. Like you shouldn't see 4 in one view. That's like way too many. So they call this basophilia. So there's an increase. So philia means like, increase, or well, it actually means like liking, like like it likes basophils technically, but when you see basophilia, this means like, well, actually it's a basophil. All right, whatever. But this means that there's an increase in basophils, okay? So there's an increase in basophils, and you can see that so clearly. This is actually like this. That's like almost like a little buzz. I should have put like a little buzzword next to this because it's like that's like whenever you see basophilia and it's like a cancer, it's like it's probably going to be CML. The translocation here is translocation 922. This is your Philadelphia chromosome. So, like I said, Philadelphia chromosome is associated with ALL as well, but not as commonly whatsoever. Very, very, it's almost always implicated in, like, if you have CML, it's likely that you have the Philadelphia chromosome translocation. And we talked about this with an immuno, but the translocation here is translocation 922. And what it's doing is it's combining, this translocation is going to make a new gene called BCR-ABL. It literally, when these two portions fuse, now we have a new gene activity, and that new gene activity is going to increase tyrosine kinase activity, which we'll talk about. And then you're going to treat it with imatinib. So imatinib, I don't know if this is generic or I don't know, but the name that, they give that imatinib is like the name of what the actual thing is. Like we know tinib means that it's a small molecule inhibitor of some sort, but the name that docs use when they talk about this stuff is Gleevec. So this is Gleevec. Boards usually sticks with like this name. I'm blanking on which one's generic and which one's not generic. One of these is called the generic, but it usually sticks with like the more scientific-y sounding ones, versus like the I forget, but like the ones that like you go to a pharmacy and say, hey, I'm here to pick up my Gleevec. You're not going to say, hey, I'm here to pick up my imatinib. Okay, so they tend to stick with the ones that are more sciencey. Types. So there's 3 types of CML. There's chronic, there's accelerated, and then transformation. So chronic, we'll talk about. Well, actually, we won't talk about. But chronic is just like it's chronic. It's insidious onset. It's the cell type that's going to be associated with it is a mature cell. You can have an accelerated type. It's basically CML with splenomegaly, but again, it's non-specific. Like if you see splenomegaly in another patient that had cancer, I wouldn't immediately be, if I saw splenomegaly in a vignette about a patient with cancer, I wouldn't say like, it's CML, Philadelphia chromosome. I would never do that because it's non-specific. But you can see it, like if you're like kind of like, okay, this could be CML because of the splenomegaly, and then you can have a transformation. So you can actually get CML as a transformation from AML or ALL. It can transform. So because these are acute forms, then it can transform into this chronic form. All right, so the Philadelphia chromosome. So normally, what it looks like normally, here's ABL, it's on chromosome 9, and here's BCR. So what happens with the translocation is a portion of chromosome 9 and a portion of chromosome 22 are basically going to switch, and then one of them is going to make a new fusion gene, right? So this one, after, this bottom part of BCR switched with the bottom part of ABL, nothing really happened. But over here, this guy, the top portion of BCR and the bottom, I said that wrong, but you got what I'm saying. The top portion of BCR and the bottom portion of ABL combined, and it made a totally new gene. And now this new gene has new ability. It's basically like a gain of function, right? It gained a function here. And the function it gained was basically to not allow growth to occur. Sorry, the opposite. It's really, really churning out tyrosine kinase activity, which is like really just turning on like growth within that cell. So that's a fusion gene, and it even says here, like this is the Philadelphia chromosome right here. So as a reminder from the immuno lectures, so since this is increasing tyrosine kinase activity, ideally you want to give a tyrosine kinase inhibitor. So like I said, like on the last slide, the tinib ending, this tells me it's like a small molecule. Usually they're small inhibitors. You can use them in like labs too, like research labs to like inhibit stuff. But the 3 ones that are at least talked about in sketchy are imatinib, dasatinib, and then nilotinib. So they have the tinib ending. This tells me, all it really tells you is that it's a small molecule. It doesn't really help you with like anything else, but it's fine. It's better than nothing. And then treatments for cancers containing the Philadelphia chromosome are going to be basically any of these because tyrosine kinase is acting way too much. We need to block it. So give a tyrosine kinase inhibitor. So those are those three. So again, it's a translocation between 9 and 22, T922. ABL is a proto-oncogene, so it's going to fuse with BCR on chromosome 22, makes a fusion gene, totally new gene, and now it increases tyrosine kinase activity, upregulates myeloid and lymphoid proliferation, and that's what leads to cancer. Here's another picture of it just to kind of show it to you. Here is your Philadelphia chromosome, and it basically leads to constitutive tyrosine kinase activity. The cell will never shut off. And remember, Dr. Satar said that's one of the features of a cancerous cell. It doesn't die when it's supposed to die, or it's growing more than it should be growing, which this kind of is going to have both. And then tyrosine kinase receptors, just to throw in some molecular bio, they always dimerize when they become activated. So this is a tyrosine kinase receptor. It spans the membrane, so it has to be able to go through the lipid bilayer. It has to have, and then it also needs to span out here. So it needs to have both hydrophilic portions and hydrophobic portions. So it is amphipathic. If remember that word, all the way back from bio, college bio. But it is amphipathic. It spans the membrane. It spans the lipid bilayer, and when it becomes active, it's going to dimerize. And this is not really unique, but it is a feature of a lot of the receptors that are involved with growth and differentiation and whatnot. A lot of the receptors dimerize. And I only mention that because some of the treatments for these receptors that dimerize is actually to block this dimerization process. And that's actually what imatinib and whatever, that's what they're doing. They're blocking this dimerization, so tyrosine kinase stops. It just it's okay, I can't get activated. So that's this. Okay. And then again, it's the exact opposite of, so remember with Bruton's gamma globulinemia, it's the BTK gene, and the BTK gene, there's no tyrosine kinase. That's why there's no B cells, essentially. It's Bruton's gamma globulinemia, no B cells, because there's no tyrosine kinase. There's no cell growth. This is the exact opposite. This is now if you have a cancer, so CML, you have a mutant, and you have the Philly chromosome CML, you essentially have tyrosine kinase that won't stop, and the cell won't stop growing. It'll just keep growing and growing and growing and growing. So you're going to give a tyrosine kinase inhibitor. It blocks that constitutive activation. Specifically, it's blocking that dimerization, and then that constitutive proliferation stops. And that's how you can kind of treat this cancer. And I absolutely love this meme. I really think it's hilarious. So chromosome 9, chromosome 22, here's your BCR ABL fusion gene. Here's imatinib being what, why? What is this, guys? Come on. Hilarious. Okay. Next, we're going to talk about, so with CML, so I did say there's basophilia. So with basophilia, you can also have increase in just your granulocytes in general. So on a CBC, this might look like you have an infection. If your white blood cell count goes up, it might just look like, I have an infection, I'm feeling sick. It makes sense. So one of the main things that to keep an eye out for when you're doing questions about chronic myeloid leukemia, sorry, I'm trying to say it out, chronic myeloid leukemia, CML, sometimes you have to differentiate between CML and just a leukemoid reaction. A leukemoid reaction is exactly what it sounds like. Leukemoid, white blood cell, reaction, it's reacting to something like an infection. So you have an increased white blood cell count, reacting to something like an infection. Sometimes the vignette will give this to you and it'll help you, but if you don't know what this is, you're going to be this does not help me because I don't know what it is. So we're going to bring it up. I've performed a few of these in the lab. It's kind of cool because I'm I wonder what it's going to be. But it's called a LAP stain. LAP stain stands for leukocyte alkaline phosphatase. So that's LAP. Leukocyte alkaline phosphatase is, think of it as, people are always well, what even is it? People think of it as basically normal white blood cells secrete it more when there's an infection, but it's normal. The normal white blood cells are secreting it. It's almost just a marker that your white blood cells are adequately responding to an infection. You would expect to see an increase in leukocyte alkaline phosphatase. It's just something that's within their cytoplasm, and you can stain for it. So you can use a lap stain. So white blood cells responding to an infection. So think of this as like a white blood cell, a part of a leukemoid reaction reacting to an infection. They're going to be lap positive. And it's like you give the stain and they turn a color. That's normal, okay? So this is like another example of positive and negative referring to the color change. But normal now is the color change, okay? So lap positive, this is normal. This means that I have a white blood cell. Well, I shouldn't say it's normal, but I should say you have a high white blood cell count because your cells are reacting to an infection. So they're gearing up. They're getting all their alkaline phosphatase ready to fight off that infection. Okay, so I put some terms that you might see when you're like doing questions or doing vignettes or something. You might see like abundant mitotic figures, and you might think like, oh, that sounds cancerous, right? Like abundant mitosis. This just means that the cell, this is like reactive hyperplasia, right? So you know when you have an infection, your lymph nodes swell, that's hyperplasia, right? That's follicular hyperplasia of the lymph nodes. It's reacting to an infection. So I've seen this, so I'm telling you, I've seen this so many times. There's actually a URL question that always gets people, and you guys are gonna do it and get it wrong and be like, but then it's gonna be fine because I'm gonna explain it right now. They always use this word and they want people to think that this means cancer, abundant mitotic figures. Just what does that say? If you asked me to describe what does abundant, or you have to describe that to a 10-year-old, what does abundant mitotic figures mean? It means there's a lot of cell growth going on. You're like, cool. Does that can be cancer, right? Like that can be cancer, but it can also just mean there's reactive hyperplasia. It could just mean the cell's growing a lot. You get the follicular enlargement because there's an infection and it's responding to it. But that's why sometimes in cancer, you do get swollen lymph nodes as well. That's also can be a sign of cancer because the cells are growing. So I just wanted to point that out there. This does not always mean cancer. It just can immediately also mean that you have an infection and the cells are responding. The other thing to note is this idea of polyclonal versus monoclonal. Normal response to an infection is a polyclonal response. Okay, so this is polyclonal. You have many different cells, so many different lymph nodes are responding to the infection, okay? Which is normal. You want a lot of different, that's the point. You want a lot of lymph nodes, you want a lot of lymphocytes responding to your infection. And then, of course, those are going to replicate monoclonally. They're going to monoclonal proliferation. But the actual response to the infection is polyclonal. Many cells are like going to respond to it. If you have a white blood cell that in CML, so again, cancer, the granulocytes. So the granulocyte cells that are part of that are cancerous, so the CML cells, they're going to be lap negative. So they're not going to change colors when you give the lap stain. And you also want to look for other features of malignant transformation. An example of that is monoclonality. This means that one cell basically is cancerous. So it always starts with one cell is cancerous and that monoclonally proliferated. And that's what's causing the increase in the lymph nodes, blah, whatever. That is not normal. Usually with an infection, yes, the replication itself is monoclonal, but you want many cells responding to the infection versus cancerous cells. That's monoclonal replicate. That's when the whole entire reaction is monoclonal. That's bad. That's cancerous. Okay. I'm telling you, there's a UWorld question that explains this really nicely. I wish I had it up so I can just be like, look how beautiful UWorld is with their explanations. Better than me, probably, especially with this. But I just really wanted to point out, if you see things like, don't get got on things that sound like they should be cancer, because it could just be, don't forget immuno, because it could just be an immuno description. Abundant mitotic figures, there's abundant mitosis happening. Okay. All right, and then this is something else that they can show you. They can show you, so here's like neutrophils, just granulocytes, and they can say like, yes, we did a lap stain, and this was the result. This is negative. You want to see a change in color to like blue, like dark, dark blue. That is, there's basically it's staining the leukocyte alkaline phosphatase. Okay, so this is a positive lap stain. This means that the increase in the white blood cells in this patient means that they're responding to an infection. So this is a leukemoid reaction. So a leukemoid reaction just means, white blood cells counts increase because I'm responding to an infection. Lap's positive. Versus they can show you this. This is a negative lap stain or negative lap reaction. that's cancerous. So if you have an increased white count, but then none of the granulocytes that are there have leukocyte alkaline phosphatase, you're like, oh, this is not good. This was a malignant transformation, essentially. Okay, cool. Awesome. All right, next. So next we're going to talk about polycythemia vera before we move on to the lymphoproliferative stuff. But we're going to talk about polycythemia vera. This is not the same as polycythemia. So polycythemia vera, this is a red blood cell cancer. So as soon as you see that, polycythemia vera, red blood cell cancer. It's not just polycythemia in general. Because remember, polycythemia, this term just means increase in red blood cell count. That's all that means. Polycythemia vera, now we have a cancer, okay? And primarily the cancer is described as having an increase in red blood cells. But remember, these are cancers of your myeloid lineage. So you can also see increases in granulocytes, platelets, all of these can be elevated. Because if your red blood cells are elevated, then likely, it was one of the precursors that's cancerous. So everything can be elevated. So that's the one thing people always forget with polycythemia vera. I think they see that everything's up and they're like, it can't be PV. PV is only red blood cells. It's not. PV can also include an increase in granulocytes and platelets because it's all on that lineage. The mutation here is JAK2. So JAK2, it's another one of those kinases. It's not a tyrosine kinase, but it's also involved with proliferation. So this is a JAK2 kinase mutation. And symptoms are related to blood hyperviscosity. So this can lead to Budd-Chiari syndrome. I should have highlighted this. This also got asked on my boards. Wow, they loved like these little chapter 6 Pathoma questions. But Budd-Chiari, I'm almost positive you'll do it in GI block like this year. But it's basically you get your liver infarcts. So here's your liver, and then you have the portal vein going to it, hepatic vein leaving. Sorry, I drew that really weird. So portal vein going in, hepatic vein going out. And remember so basically if you have too many red blood cells, your blood gets really viscous. It gets really thick because now there's more cells than fluid. So it's like too many cells for overall. Because remember, blood is red blood cells, white blood cells, platelets, like just serum like other proteins like albumin, stuff like that, water. So other things, serum, plasma, that's all of what your blood is. So if you have too many red blood cells now it's like there's too many red blood cells in that volume of blood that you should have. So the blood gets really thick. It's like instead of being like blood's like water, now it's like molasses. So what can happen and what Budd-Chiari syndrome is patients with polycythemia vera, or even honestly just like any polycythemia, any instance where you have too many red blood cells, you can actually get a thrombus in your hepatic vein. So now blood can't leave the liver and the liver dies. It infarcts. Because now it's like the blood can't get filtered. So it's like it dies. So then classically when they're trying to explain to you polycythemia vera is classically they'll say you itch after a shower. So which is really interesting. And I think the reason they asked this is the physio behind it. So again, I know I don't have mast cells on the little charts that I wish, like the little lineage charts, but we're still in the myeloid lineage side. Mast cells, I know they're like tissue derived, but they still kind of come from that lineage, just very basically. Very basic description. They still can come from that lineage. So when you take a shower, so they can be increased. You can have increased mast cells. You take a shower, it's really hot. It can actually trigger histamine release. Okay. And sometimes they'll ask that mechanism. Like sometimes they'll even ask like, why do patients with polycythemia vera itch after a shower? And it doesn't have anything to do with the red blood cells. It has to do with the mast cells. There's increased mast cells and they're increasing histamine and it makes them very itchy. All right, so you treat it with therapeutic phlebotomy, which sounds like my absolute worst nightmare. You basically have to go get your blood drawn to remove blood from your body. No, and you go like, every, I don't know clinical stuff, but you probably go like, I would at least guess like once a week, which again, worst nightmare. But back to this idea of polycythemia vera is not polycythemia. They can ask you really good physio questions with this. So for example, and this is my whole, don't memorize this whole thing here. Just think about it. Just sit here and be like, let me just think about it. I know physio, I'm a physio genius, right? So I'm just going to sit here and think about it when you get to it on your exam. So let's think about a pathology state. Let's think about, because it's not just going to be like red blood cells are high. That's the answer is polycythemia vera. No. Boards is smart. They know that people know that. They're like, well, how do I know that you're not just in Colorado and now I need more red blood cells because I'm in Colorado? And you're like, great idea. Great point. So what they do is they kind of give you like, they'll make the answer choices like, oh, this is polycythemia vera. This is, low oxygen. So you're increasing your red blood cells to carry more oxygen. Or it can be another cancer. You have a renal cell carcinoma and now it's producing ectopic erythropoietin. So now it's just more red blood cells out of nowhere. So those are going to be your answer choice. And you're like, damn. So what they're going to give you as well in the vignette are some oxygen studies, basically. They're going to give you red blood cells. They're going to give you oxygen studies. They're going to give you EPO levels. So let's just think about it. Let's just go through it. So in polycythemia vera, we know that the red blood cells are high. So all three of these, we know the red blood cells are high. However, if the red blood cells are high, what do you think? I should have had you guys pause it and do this, but what do we think EPO is going to be? Erythropoietin. It's going to be low because this is negative feedback. Physiology is just one big negative feedback loop. The body's like, hey, we don't need any more red blood cells. We have hella red blood cells, so we don't need any more. So EPO is going to be really low. How about your SaO2? And again, this is SaO2. This is oxygen saturation. And actually, this is the one that I think is the trickiest. So oxygen saturation, think of oxygen saturation as the red blood cell, so the red blood cell itself. So we know that there's tons of red blood cells around. So we know that there's just many, many, many red blood cells. But now the SaO2 basically tells you, let me zoom in on one of these red blood cells and look at its binding sites for oxygen. Let's look at it. How much does this red blood cell have an affinity for oxygen? Or how much does this red blood cell, does it have all the is all the spaces on the hemoglobin that's carrying the oxygen, is that completely filled? That's basically what SaO2 is telling you. What does that, I know all the red bloods, I know the red blood cell count's really high, but if we look at each individual red blood cell, how is its affinity for oxygen? Is it low? Is it high? Is it normal? What's going on with that? How are the spots on the hemoglobin looking? So the SaO2 in polycythemia vera, if you think about it, it's going to be totally normal because really this is just a cancer where the red blood cells are increased. The body tries to compensate. It decreases EPO. It's like, I'm going to try and compensate for this because there's nothing wrong with the rest of the body, right? It's like, okay, let's compensate. So it decreases EPO. But again, there's nothing wrong with the red blood cell. Red blood cell's fine. This can carry oxygen great. These are great red blood cells. There's just more of them because of this cancer aspect. So SaO2, so your saturated oxygen, is going to be normal for polycythemia vera because each individual red blood cell is fine. Good? Cool. Next one is going to be reactive polycythemia. So like I said, polycythemia does not equal polycythemia vera. Reactive polycythemia, this could be physiologic because you're up in Colorado. So this is the body's normal response to low oxygen. You can have a reactive polycythemia. And again, this does happen. This does happen when you go to a place with notoriously low oxygen and you're not used to that. So you're going to have a high red count. We know this. How about EPO now? EPO is going to be high here. So EPO, because again, that's what's even causing the red blood cells to be high, right? That's what's causing the reactive polycythemia is the body sensing those oxygen receptors. Those oxygen receptors are sensing the low oxygen and the body, it's basically triggering this response in the body, right? Hypoxia-inducible factor gets produced. It's going to go trigger the release of more red blood cells from the bone marrow. It'll do all that. You'll get some, what are those things called? You'll get some reticulocytes maybe coming out, some polychromatophilic cells. And again, you'll also eventually, since hypoxia-inducible factor is a transcription factor, it takes a little bit of time to transcribe new hormones. So after a few days, 2 or 3 days, eventually you'll get EPO. And then when you get that EPO going up, now you'll get that increase in the red blood cell count. So again, if you've ever gone to Colorado, somewhere where the oxygen, the oxygen pressure is the air, I don't know why I said oxygen, the air pressure is really low. If you've ever gone somewhere like that, you're going to feel really weird the first like 2 days, but then your EPO gets made, you make more red blood cells, and then you're fine. That's why people aren't like passing out when they go work out in Colorado. They're fine. Okay, so the EPO is high here because that's the whole reason that's what's making the red blood cells high. So this is like your low altitude things. And then how about your SaO2? Your SaO2 is going to be low here. And the reason why is because you have to think back to POEM. See, it all comes back second here. But now if we individually look at this red blood cell, now it's, again, it's almost like the increase in the red blood cell count is compensating for each individual red blood cells not having a higher oxygen saturation. That makes sense? So it's like, okay, this red blood cell is not going to be able to, have a high, like, does not have as high an affinity for oxygen anymore because I'm at high altitude now. So it causes a ventilation lung disease, and the SaO2 decreases. So the body tries to compensate by shooting out more red blood cells. Okay, cool. All right, and then lastly, we have our reactive polycythemia in a pathologic sense. So now this is something like ectopic EPO production. So again, our red blood cells are going to be high, our EPO is high, but the EPO is high here because it's pathologic, it's cancerous. How about your SaO2? Your SaO2 is normal. So your SaO2 is going to be normal because, again, there's nothing wrong with these red blood cells. There's nothing wrong with its ability to carry oxygen. It's just now EPO is being produced when it shouldn't be produced, and that's what's causing the increase in the red blood cells. Here, EPO is being produced when it should be produced because the SaO2 is low. The oxygen saturation is low, so EPO gets produced to increase the red count. Here, the SaO2 is normal, but still you're getting EPO, and I'm like, you're reading that, you're like, wait, why? Like, why is EPO being produced? So what causes that is ectopic EPO production. Renal cell carcinoma is like known for doing this. It produces a lot of EPO. It also produces some of the lung cancers can also produce ectopic EPO. And remember, the word ectopic just means this hormone is being produced outside of its location, its normal location. Remember, with ectopic pregnancies, an ectopic pregnancy is a pregnancy happening outside of the normal area that it should be happening, which is in the uterus. Now, an ectopic pregnancy, usually it's in the fallopian tubes. That's not where you should be having pregnancy. Here, you have a kidney cell, like a renal cell carcinoma, producing EPO outside of where it should be. Okay, cool. Or like a lung cancer is producing EPO. We're like, why is EPO coming from the lungs? It's like, what's going on there? It's just outside. It can even be like, just like with the ectopic pregnancy, it can still be in the same like general area, but it's outside of the normal area for it. And that's what happens with renal cell carcinoma. It's like the cancer itself is producing the EPO. Cool. All right. Great. Next, essential thrombocythemia. So essential thrombocythemia is not the same as thrombocythemia or thrombocytosis. You can also see essential thrombocytosis is not the same as thrombocytosis, just like what we just did with polycythemia vera. You can see clearly in this slide, tons of platelets. Just all of these purple dots are platelets, even these bigger ones. These are all platelets. Great, all platelets. So with this, it's the same as polycythemia vera in that, yes, platelets being elevated is the main thing, but this is a myeloproliferative disease coming from a myeloid stem cell in some capacity. The red count's going to be up. The granulocytes are going to be up. Everything's going to be up. Again, yes, the platelets are up. So just from this slide here, or this like bullet, it's the exact same as polycythemia vera, right? Because everything's elevated in both. But now, like, obviously the pathology is different and like the diagnosis is different. So the mutation here is a JAK2 kinase mutation, same one as polycythemia vera. And the symptoms here are going to be increased risks of bleeding. And people are always like, what? Like, you have so many platelets, so why are patients bleeding more? And the reason why is because these platelets, yes, they're there, but they're not functional. They don't work properly. So bleeding time would be up, right? Yeah. All right. And then you also have an increased risk of thrombosis in other ET patients because now all those platelets are there. Guess what? All those platelets are functional. So now they're functioning too much and they're making clots. So there's very different presentations of this, but you can usually figure it out with the question. You can tell, like they'll be explaining, you know, a patient that's bleeding too much or clotting too much or bleeding too much, and they'll tell you there's a JAK2 mutation and then show you this slide and you're like, okay, yeah, that's essential thrombocythemia. All right, so next, moving on to those lymphoproliferative leukemias. So these are cancers forming from any cell that derives from a lymphoid stem cell. So same idea. So a lymphoblast, that's going to be your acute lymphoblastic leukemia. Your B or T cell out in the peripheral blood. So again, this is mature. That's going to be your chronic lymphocytic leukemia. B or T lymphocytes out in the lymph nodes, so out in the secondary lymphoid tissue. These are your lymphomas. We are not covering them right now. We're going to do lymphomas at the end. And then plasma cell cancers. These are your plasma cell dyscrasias, including multiple myeloma. So first is ALL, so acute lymphoblastic leukemia. This is characterized by lymphoblast in the bone marrow. So here's kind of the slide I was talking about when you just see a whole slide of just blasts. If I were to see this, like when I was like, you know, doing hematology lab stuff, if I saw this, I would not be able to tell you like, oh, this is CML. No, that's not a good one. This is ALL or AML, like one of those ones that are that have blasts. I can't tell the difference between a myeloblast or a lymphoblast. I just know that these are blasts. So all you really do is mark down the presence of blasts. Okay, so there's really no way. It's kind of like when I was talking about, like, if you see a lymphocyte on a peripheral blood smear, just like a normal, you know, lymphocyte, you can't tell if it's a B or a T lymphocyte. Kind of the same here. You can't tell if this is a myeloblast or a lymphoblast, blast or blast. But you can see this is what blasts look like. The nucleus pretty much takes up the entire size of the cell. There's very little cytoplasm, but the cytoplasm that is there looks very glassy, very blue. These cells are massive. And again, really, there's going to be a lot of them. If it's a blastic cancer, there's going to be a lot of them in just like one frame. So lymphoblasts, other things that they can tell you, since these are immature cells, they're going to be TDT positive. If you were to try to give MPO, be like, all right, let's see if these are myeloblasts. You try to give an MPO stain, they're not going to stain. There's no outrods here because, again, no granules, so you can't have outrods. So what you can do to kind of tell you, like, you know, what type of ALL is it? Are these B cells? Are these T cells? Like, what is it? You can use those CD markers, right? So B cell ALL is more common. So that's just like a fun, like, if again you forget you're on test day and they're like, okay, they show you this peripheral blood smear, they tell you it's TDT positive, doesn't stain with MPO. You're like, great, this is either B cell ALL, this is T cell ALL. Then they're like, all right, you have CD10, 19, and 20. And you're like, wow, I literally cannot remember for the life of me if that's a B cell marker or a T cell marker. B cell is more common, so you can always go with that. But just remember the markers. So CD10, CD19, CD20, this is going to be markers for a B cell ALL. CD3, CD4, CD7, these are your markers for a T cell ALL. Okay. Obviously like 2, 5, 8, but these are the more common ones that they tend to look for, at least what I would tend to look for in the lab when I would test for B cell or T cell ALL. Like I said, usually it's a childhood cancer, but I wouldn't put age past the like vignettes. They might just give you a random person that's like 40 with ALL and you're like, okay, well, but commonly it's in children. This is like we talked about with acute megakaryocytic leukemia, is associated with Down syndrome before the age of 5. ALL is associated with Down syndrome after the age of 5. And I wrote exam Q here. It's not actually an exam Q. I really should change this. This is what you would see a typical exam Q, exam question on ALL. It's like a fun fact, but they like to ask it. Maybe I did highlight this because it's on the exam. I forget, my exam at least. I don't know what's on your exam. But one of the things that's really interesting about ALL is that it's super responsive to chemo. Super, super responsive. So you give chemo and you're like, wow, this is great. Like this like 4-year-old is responding almost perfectly to the chemo for the ALL. This is great. But you also have to give prophylaxis to the patient's scrotum, if it's a male, obviously, and to the CSF. the cerebrospinal fluid, because chemo can't cross the blood-brain barrier or the blood-testes barrier. So it's just like a really weird little thing. You also have to give prophylaxis to the scrotum and CSF because the chemo isn't going to hit those locations and you don't want the cancer to go there. The mutation causing the ALL dictates the prognosis. Sorry, oh my gosh. The mutation causing the ALL indicates the prognosis. So if it's a T1221, this is a good prognosis. This is usually the one in children. That's the one that typically will respond well to the chemo, but you have to give to the scrotum and the CSF. If you have the Philly chromosome mutation that causes an ALL, this is a bad prognosis. And this is kind of what I was saying. You can have a Philly chromosome CML that transforms into an ALL. Anytime you have a transformation, not good. That's never a good prognosis. So that's usually what happens here is like if you have an adult with ALL, they likely had CML that was never detected, and now it had transformed to AML. I think I might have said it backwards. I'm sorry. I said it backwards earlier. CML transforms to AML or ALL, not the other way around. Because you had a chronic cancer, and then now all of a sudden it transformed. Now it's blastic. Not good. That means it's like a totally different type of thing happening. All right, CLL, this is your chronic lymphocytic leukemia. This is the one that they tell you nicely in the name. So this is the most common leukemia. This is leukemic B cells that are going to proliferate. So they're straight up telling you these are going to be B cells. It's always present in older adults. I hesitate to say always because of people throwing you off. But this could be an instance where they're not going to give you a 10-year-old with CLL. I think this actually is always like an elderly cancer, I think. But I would just say any adult. For your exam, just go with any adult. You can count it. Maybe they don't have to be over 65. I'm telling you, I really hesitate with age, with like hemonc stuff. So this is an instance where if you have generalized lymphadenopathy in a patient over the age of 65, you can immediately think of CLL. That's true, because again, it's like it is a lot more common in older people over the age of 65. So you can see B symptoms here and splenomegaly and hemolytic anemia. These can all be signs of CLL. The hemolytic anemia just has to do with, actually I talked about it with the anemia session whenever I did that one. I talk about how in certain cancer states you can get these hemolytic anemias. So hemolytic anemia is not common. It's not unique to CLL. That's why I didn't really highlight it. Just like splenomegaly is not unique to CLL. Remember with CML, if you have the accelerated form of CML, that presents with splenomegaly. These are not unique at all. But if you combine these three things together, so the B symptoms, the fatigue, the bleeding, the whatever, the splenomegaly, and the hemolytic anemia, you can kind of think in an elderly patient, be like, okay, this could be CLL. These B cells, so this is kind of what's annoying. These B cells, these leukemic B cells, express both CD5 and CD20. And you're like, nice, that's a T cell marker and a B cell marker. So they are B cells, but they can express CD5 for whatever reason. But the big giveaway for this is you see smudge cells and leukocytosis. So leukocytosis obviously is going to be an increase in your white blood cell count, which we know that you're going to see an increased white blood cell count. Maybe they'll do a lap stain to see let's see if it's because the granulocytes, there's too many granulocytes. Usually it's not, usually it's lymphocytes. Like in this image, when I'm looking at this, actually leukocytosis is the leukocytosis that arises. So the increase in the white blood cell count is because of the lymphocyte increase. So look at all these lymphocytes in this peripheral blood smear. These are all lymphocytes. Again, not lymphoblasts. These are all lymphocytes, every single one of these. Even though that's kind of pink. I think it's a lymphocyte still. This is a neutrophil. This is a neutrophil. So we have two neutrophils. We have all these lymphocytes. And then maybe that's a smudge cell. I would maybe this is the beginning of a smudge cell. These are smudge cells. So here's a smudge cell. Here's a smudge cell. Smudge cells are literally like when you're making the when you make hematology slides, you like put a drop of blood on a slide and then you use another slide to make like a smear. I was so bad at making them at first. It's better now. But when you make the slides, normally the cells shouldn't degrade or anything, like, because they're fine. But for whatever reason, in the CLL, these leukemic B cells, they smudge when you make the smear, and that's usually a dead giveaway that this is CLL. So putting all of this together, you can be like, okay, this is CLL. So CLL. So if a patient has CLL, oh yeah, this comes up. I think Satar talks about it, and it's kind of confusing. But if you have CLL, and then the CLL, so we're in the blood, we're in the peripheral blood. We're like a lymphocytes, usually B cells, leukemic B cells in the blood. And then those B cells go over to the lymph nodes. So they now go to the secondary lymphoid tissue. They go to the lymph nodes. All of a sudden, now it's called small lymphocytic lymphoma. Okay? It's kind of like a monocyte to macrophage thing. They're the same thing. They're called monocytes in the blood, macrophages in the tissue. This is basically like it's CLL when it's in the blood, but then when it goes to the lymph nodes, now it's SLL, okay? Small lymphocytic lymphoma, they're the same thing. Then if SLL eventually progresses, now we're in the lymph node. So now if we get a new cancer that's arising from those cells within the lymph node, now we have a lymphoma. It's called diffuse large B-cell lymphoma. If that progresses to that, that's called the Richter transformation. And the cancer is going to be very aggressive. I'm telling you, anytime you see a transformation, it's going to be super aggressive. I will talk about this again when we talk about diffuse large B-cell lymphoma. The most common cause of death with this cancer is hypogammaglobulinemia, which always gets people. And the reason why is because, like I said, the most common type of CLL, usually, actually not even the most common type, usually CLL is B-cell CLL. Usually the lymphocyte that is increasing, the cancerous lymphocyte, is a B-cell. So what happens is, since that's growing so much, it's suppressing normal B-cell proliferation in the bone marrow, and you have increased proliferation of your leukemic B cells. These leukemic B cells, they're just kind of there. They're not doing anything. So they're not producing antibodies at all. So patients usually die. Patients with CLL usually die from an infection. Okay? And then you're like, wow, how did they die of an infection? And then you realize they're not making any antibodies. And then you're like, this is probably, CLL. Multiple myeloma. So multiple myeloma, this is a malignant proliferation of the plasma cells. So basically when you have multiple myeloma, one of the triggers, so to speak, or the stimulant of the plasma cells is going to be high IL-6 levels. So high IL-6 is going to stimulate these plasma cells, and eventually these plasma cells are going to form osteoclastic bone lesions. And again, I know bone stuff isn't really covered yet, but remember, clasts are going to break down bone. So what happens is cancerous plasma cells activate something called rank on osteoclasts. There's rank and rank ligand. Again, that's covered in Pathoma for when he talks about MSK. But cancerous plasma cells will activate rank on osteoclasts. That's going to trigger it. And remember, osteoclasts break stuff down. So it's going to start breaking down bone. So what it can look like are punched out lesions, literally like it got a punch biopsy and it punched out lesions of the bone, of, the skull, of, anywhere, any bone. And this is the most common primary bone cancer. Usually bone cancers are metastasis from other locations. This is basically a primary bone cancer. Like, these osteoclasts are cancerous. Okay, and then how do you basically diagnose multiple myeloma? You'll see an M spike on serum protein electrophoresis. So here's a normal serum protein electrophoresis. I'm sure you've covered this with, alpha-2 antitrypsin or something like that. You've covered this before. You should know these spikes just for life. They'll randomly show you this sometimes. But this is a normal one. For a multiple myeloma patient, the gamma spike is going to be huge. And this is your gamma globulin. So this is obviously your antibodies. Is your antibody spike. So your antibody spike is huge. And everyone wants to say, so this is called, if you have a huge gamma spike in multiple myeloma, they call this an M spike. Everyone wants to say that the antibody that's causing this spike is IgM. Please promise me you won't say that. Because, multiple myeloma, M spike, they're like, oh, it's got to be IgM. Don't get got. Please just make that promise to me. It is usually IgG. Sometimes it's IgA. It is never IgM, okay? So don't pick IgM, but it is called an M spike. It is, but it's for multiple myeloma. That's what the M is for. It's not for IgM. All right, because the gamma globulin spike is made up of all the antibodies, IgA, IgG, IgE, IgM. No IgD, because no one really knows what IgD does. And then it's like, so what antibody is responsible for this? IgG or IgA? Never IgM, never IgE for multiple myeloma. Other things you can see with multiple myeloma, you can see rouleau. Rouleau is nonspecific, but I wanted to show it to you. This is rouleau. It's when red blood cells like stack like coins. So this, here we go. Some little ones here. So this is rouleau. Again, non-specific. You can see rouleau for many different reasons. A lot of the times just normal infections can cause rouleau. But basically what you're doing is, since you're increasing the amount of proteins that are in the serum, you can physically see that this is a serum electrophoresis. We clearly are going to have more proteins because we have this huge gamma spike. So this is basically telling me the amount of proteins in the serum is going to change. Proteins are negatively charged primarily. So what you're doing is you're changing the charge of the serum, and it's going to actually mess with the red blood cell charge, and then they stack because they start to like stack on top of each other because the charge is like messed up in the serum. But you can see why this is completely nonspecific. Like there's got to be a lot of other stuff that messes with the charge of the serum. If you have too many proteins, too little proteins, you can see rouleau formation. But it's just if it sounds like multiple myeloma and then they give you rouleau, you're like, okay, this is probably multiple myeloma. Most common cause of death is infection. Again, plasma cells, they're not real plasma cells. They're cancerous. They're just they are secreting protein, but they're not secreting antibodies. They're not doing what they need to be doing. So again, it's kind of like a hypogammaglobulinemia. Again, you're not producing any antibodies. You're not producing normal antibodies. Clearly you're producing tons of IgG, but it's not doing what it should be doing. And then other things you can look for, they're called free light chains. This is so free light chains. So imagine these are plasma cells, right? So we know plasma cells, these are your antibody factories, right? I always draw them like this to remind you to look for the perinuclear halo, because this cell is going to have tons of protein production. It's making tons and tons and tons of antibodies because this is a plasma cell. Remember, whenever you're making antibodies, you make heavy chains and you make light chains. Well, in multiple myeloma, these cancerous plasma cells are making so many antibodies, like so many, that to the point where they just start churning out so many light chains, so many. And there's no heavy chains for them to bind to, essentially. Because again, it's just chaotic. Nothing is normal. Nothing is correct. They're not making one light chain or two light chains for two heavy chains. They're just secreting everything they can because they're cancerous. So they make a lot of extra free light chains. That's what it is. It's these light chains without heavy chains. Because again, cancer cells, they don't really know what they're doing. They're just trying to wreak havoc on the body. So when these free light chains are present in the urine, because there's really nowhere, there's so much in the blood, they eventually go to the urine, they get filtered, and then they leave into the urine, or they go to the kidneys to get filtered and they leave through the urine. Those are called Bence-Jones proteins. If you see free light chains in the tissues, this is called amyloidosis. Amyloid is, I think you'll cover amyloid in like next block in POM block. So I didn't go into amyloid, but just know that you can see these free light chains throughout the body. They can even go to the tissue. They can go everywhere. But the ones that you need to know, at least for this, is your Bence-Jones proteins. This is diagnostic for multiple myeloma. So what are Bence-Jones proteins? Like I said, here's your B cell, here's an antigen that stimulates it to turn into a plasma cell. And now, since this is a cancerous cell, they're producing just tons and tons and tons and tons of light chains, heavy chains, whatever. So here's your immunoglobulins. So with light chains, you can have, the Greek letters, kappa or lambda. That looks like a lambda, I think. It might not be. But I think it's lambda and kappa. Guys are probably yelling at me like that is not lambda. But anyway, so in the urine, these can now escape because now we have tons of it. See, like these arrows are really thick. We have tons of them for no reason. They can actually deposit into the urine. Those are your Bence-Jones proteins. They can also, since remember, they're in the blood, they go to the kidneys to get filtered. If there's like so many, like if there's just like tons and tons and tons of light chains, they can actually deposit in the kidney itself because the kidney can't filter as quick as it's coming in. And you can actually cause kidney failure. And actually, like, I actually knew someone with multiple myeloma that their cause of death was kidney failure, and it's because of this, which is kind of crazy, like, to understand that process. But again, I just wanted to remind you what plasma cells look like. Here is the perinuclear halo. So here's the nucleus, here's that perinuclear halo. And again, this is like where all of the, the endoplasmic reticulum is that's forming, and just they're churning out antibodies. And again, here's an antibody. The light chains are these guys over here. And then the heavy chains are in blue. And then here's like plasma cells. This would be like what multiple myeloma in the bone marrow looks like. Just like tons of plasma cells everywhere, like to the point where it's just like, whoa. Okay, lymphomas, not as long as the leukemias, but the lymphoma, because there's only two types. But lymphomas, think of it in terms of large, painless, and it's important to note painless, we'll come back to it, lymph node and B symptoms. So if you have these very massive lymph nodes, they don't hurt, and you have like B symptoms, fatigue, bleeding, blanking on all of them, just non-specific, I'm not feeling well symptoms, essentially. Sometimes the doctor will just want to take a biopsy right away. And then they'll see these malignant lymphocytes and be like, okay, I know that this is a lymphoma, but is it Hodgkin's lymphoma or non-Hodgkin's lymphoma? So the cell that kind of differentiates that, like, is this Hodgkin's or non-Hodgkin's, are called Reed-Sternberg cells. If there are not Reed-Sternberg cells present, then this is non-Hodgkin's lymphoma. Non-Hodgkin's lymphoma is all the cells that make up that mass, so the mass that you biopsied, every single cell in that is malignant. Versus Hodgkin's lymphoma, this is the presence of Reed-Sternberg cells. In this mass, the Reed-Sternberg cells only are the cells that are malignant. Okay? All the other cells in the mass are just reactive to the Reed-Sternberg cell. They're like, oh my God, what is this? And they react to it. Versus non-Hodgkin's, there's no Reed-Sternberg cells. Every single cell there is malignant. Okay. Back to this. So the idea that it's a painless lymph node is really important, because if you have a painful lymph node, usually that's because if you have a leukemoid reaction, your body's reacting to an infection. There's inflammation occurring. Inflammation, one of the signs of inflammation is pain, honestly. You have redness, pain, heat, all that jazz. So usually if you have painful lymph nodes, like if your lymph nodes swell and you're like, ugh, I'm dying, they hurt so bad, that's usually like you have an infection of some sort. Painless lymph nodes are usually like, oh, that, like, again, not saying that it can't not be an infection, but usually painless lymph nodes get people a little bit more scared. I had friends before that have texted me, they're like, I have this lymph node and it doesn't hurt at all. Should I go see a cancer doctor? And I'm like, no, just... But I think people look it up and it always says, painless lymph nodes is usually a sign of cancer. That's really all. That's really all they are getting at, is that there's no inflammation usually. Usually there's no inflammation that's causing that size. So they're like, it's got to be something else that's not inflammation related, so to speak. And then this is just like a meme of like how they named Hodgkin's, non-Hodgkin's. I think this is a true story, because it's like the two doctors that discovered it were Dr. Hodgkin's and Dr. whatever this guy's name is. And they're like, cool, non-Hodgkin's. I'm like, okay. All right, anyway, so what are Reed-Sternberg cells? So Reed-Sternberg cells, these are these cells right here, this one cell right here that has basically two nuclei, and it looks like they're owl eyes staring back at you. At first, I never used to see it, but now I immediately see like literally like an owl staring at me, and I'm like, whoa. But that's a Reed-Sternberg cell. It has this owl eye appearance with a multi-lobed nucleus. Again, those are the eyes. And usually they're mirror images of each other. So like if you have one here, you have the one on the other side. That's what makes the eyes. These are CD15 positive and CD30 positive. I know a lot of CD markers to memorize, but we have a good way to remember it. So we have two owl eyes times 15 gives you 30. Done. Two owl eyes, CD15, CD30. Done. Easy enough. I've seen questions that have asked for these, but a lot of the times they either won't tell you it's a Reed-Sternberg cell, or they'll show you a biopsy, like they'll show you something like this, like a biopsy of this, or they won't say anything. They'll just say a cell was located that's CD15 positive, CD30 positive. Because if you think about it, if you know if there's Reed-Sternberg cells or not, you can rule out like all the like the non-Hodgkin's lymphoma or all the Hodgkin's lymphomas with the presence of the Reed. So it's a really important cell. Usually what a Reed-Sternberg cell even is it's a B cell. So usually it's a B cell that's cancerous. Again, like I said, in Hodgkin's lymphoma, this is the cancerous cell. But what's interesting is it's a B cell that has CD15, CD30. It has no other B cell CD markers. No CD10, no CD20, no CD21, no CD19. It just has 15 and 30. Really interesting. So here are the lymphomas. So we have our non-Hodgkin's lymphoma. We're going to talk about follicular, mantle zone, marginal cell, diffuse large B cell, Sézary syndrome, small lymphocytic, which we already kind of touched on, and then Burkitt's. And over here for Hodgkin's, we have classical Hodgkin's, or we have nodular lymphocyte predominant Hodgkin's. And then from the classical, it can get broken up into 4 additional types. But honestly, these 4 additional types are just based on the type of because remember, like I said, with Hodgkin's lymphoma, the Reed-Sternberg cell is the cancerous cell. All the other cells around it are just reacting. This is basically telling you like all the cells around it that are reacting. So are there a lot of lymphocytes reacting? Are there not a lot of lymphocytes reacting? Nodular sclerosing is like the cell, like, is there any cells reacting? Or is it mixed cellularity? Are there multiple different types of cells reacting? This is like, lymphomas are like known for the keywords and the buzzwords and stuff. So I have lots of memes for these to help remember. But this is what I would say. Know your translocations if they give you one. Know your typical patient population and presentation. They tend to stick to these a little bit more than the leukemias. And then buzzwords. And I point them out obviously in these slides. So for example, don't do this, but an 8-year-old African boy, boom, it's Burkitt's lymphoma right off the bat. Or a starry sky appearance is also like another buzzword for a lot of these actually. So most commons. So the most common site in the body for a lymphoma that does not develop in the lymph node, because yes, I know I said that lymphomas develop in the lymph node, but you can actually have extranodal lymphomas. They're not actually very common at all, but the most common place that it can happen are in the stomach, and it's because of H. pylori, which is a bacteria, which you'll learn about in GI block, but it's a microbe that is considered a carcinogen because it literally causes cancer. And that's where it causes it, but it doesn't cause cancer in the lymph nodes. It causes cancer in the stomach because it lives in the stomach. It loves the stomach. And then the second most common site of an extranodal lymphoma are Peyer's patches. But technically Peyer's patches are like lymphoid tissue. It's just in the GI tract. It's not technically, it's like in the small intestines, right? So it's not technically a lymph node, but like Peyer's patches technically are lymph nodes. So stomach is number 1 and then Peyer's patches are number 2 for extranodal lymphomas. But the most common lymphoma overall out of, non-Hodgkin's, Hodgkin's, just overall is follicular B cell. So your Hodgkin's, we're going to start with Hodgkin's. So Hodgkin's lymphoma, this has a bimodal frequency. So what bimodal frequency means is that usually it's going to be 15. So between 15-year-olds and then between 15 and 35-year-olds is usually who gets Hodgkin's lymphoma. There are A and B symptoms. So your A is your asymptomatic. B is going to be your unexplained weight loss, fever, night sweats. Like I always say, your B symptoms are the ones that are your plan Bs. You can't really use these to diagnose anything. And then A, asymptomatic, of course, but you're going to use anything unique to help you actually diagnose what's going on. Clinical staging. So this is the Ann Arbor classification system. I know it literally doesn't matter, but I'm just putting this here in case you find other classification systems. I'm pretty sure that Satara uses Ann Arbor. He's a pathologist. This is what pathologists use. But regardless, there's other ones out there. So stage 1 means that a single lymph node region is involved. This is the quote unquote best stage of a lymphoma because only one lymph node is involved. You caught it very early. Stage 2 is 2 or more, not even a single lymph node, I'm sorry. It could be a lymph node region. So like the region of the armpit, for example, that can be a stage 1. It stayed within that one region. Stage 2 is 2 or more lymph node regions are involved. Stage 3, 3 or more. And then stage 4, now it metastasized, it went to organs. And like I said, rarely extranodal. It's usually just going to develop in the lymph nodes, usually a B cell that became cancerous and it turned into a Reed-Sternberg cell. So with Hodgkin's, there's the two types, right? If you remember that flow chart. The first type is nodular lymphocyte predominant. That's only about 5%. And what nodular means is that it looks like there's nodules in only one area of the lymph node. And I'll show you what that looks like. But that's how they classify it. They're like, you know what? That looks like a nodule. It's nodular, Hodgkin's lymphoma. And there still obviously are going to be Reed-Sternberg cells. The classical type, this is your 95, this is the bulk of your Hodgkin's lymphoma. It's diffuse, meaning like the entire lymph node is affected with these cells. There's 4 subtypes. The most common one is nodular sclerosing, that's 60 to 80%. Your second most common is mixed cellularity, 15 to 30%. Lymphocyte rich is 5%, and then lymphocyte poor is 1%. But what's interesting is the prognosis gets worse as you go from nodular sclerosing all the way down to lymphocyte poor. So let's say you find Hodgkin's lymphoma and the pathologist deems it to be lymphocyte poor. That's a really bad prognosis compared to you have a Hodgkin's lymphoma and the pathologist calls it nodular sclerosing type. That's a little bit better of a prognosis than any of the other ones. And again, like I said, look for your Reed-Sternberg cells. They are pathognomonic for Hodgkin's lymphoma. Every single one of these will have Reed-Sternberg cells in some way, shape, or form. So here's your nodular sclerosing. I know it's kind of hard. I know these histo slides are going to be terrible. I am so sorry. I personally do not think they will give you histo slides unless it's very obvious that they're trying to show you Reed-Sternberg cells. Because I think that these are just we are not pathologists. I don't think we need to be able to tell, like, look at the screen and be like, oh, that's nodular sclerosing. No, but I will try to point it out as best as I can because I think pathology is interesting. I think that reading histo slides is weird. Is cool, which makes me weird. All right. But anyway, the classic type of Hodgkin's and the subtype nodular sclerosing. This is the most common type, right? This is most prevalent. It occurs in younger patients. Again, that could be why the prognosis is so good. You usually see a mediastinal mass. So I feel like on the exam, this was meant at least my exam for hemonc, this was mentioned. There was a mediastinal mass in the patient. The patient was like 20. And then when they took a biopsy of it, they found Reed-Sternberg cells, and then they also found this collagenous tissues that subdivided the entire lymph node into what looked like nodules. So what they're basically showing you is, see all these pink regions. So here, this is all collagen, and in between the cells too, this is all collagen. So this is all collagen, and it's basically subdividing this entire lymph node into nodules, which is why we have sclerosis from the collagen and nodular in the name. And the nodules, so here's like a massive nodule. This is comprised of obviously your Reed-Sternberg cells as well as granulocytes and then other T cells. So I'm trying to find a good Reed-Sternberg cell. I literally cannot. I am not a pathologist, but maybe nope, not even gonna attempt. But usually the Reed-Sternberg cells look something like this. I just don't see its counterpart. But they're like big cells because it looks like it's like 2 cells almost put together. Okay, great. But anyway, that's nodular sclerosing. You have sclerosis, you have nodules, and you have Reed-Sternberg cells. Next, we have lymphocyte rich. So we're obviously going to have our Reed-Sternberg cells again. And we also have something called Hodgkin cells. Hodgkin cells look a lot like Reed-Sternberg cells, but there's only one nucleus. So, I mean, don't take my word for it, but this apparently does not look like a Reed-Sternberg cell, but it has one nucleus. Here's another Hodgkin cell. Like I said, I really don't think they're going to ask you to diagnose these weird other cells. If they were to give you a slide for lymphoma, they're going to show you the Reed-Sternberg cell. I would almost put money on it. But just kind of knowing, this is a subtype of your classic Hodgkin's lymphoma, and the surrounding cells obviously are going to be lymphocytes. So these are all lymphocytes surrounding, and then you have these Hodgkin cells everywhere. Oh, you know what? This is probably a Reed-Sternberg cell now that I think about it. So this is a Reed-Sternberg cell. These are probably Hodgkin cells, the one with the single nucleus. So let's do that again. So what's circled are, so those are your Reed-Sternberg cells, I think. And then I think these single nuclei ones, these are going to be your Hodgkin cells here and here. Maybe here. This is questionable. But anyway, So that's what I think. Next subtype of classic is mixed cellularity. It's going to be, you're going to see Reed-Sternberg cells, of course, because that's all that's all of your Hodgkin's lymphoma subtypes. So you can see Hodgkin cells, which I think are these guys here. So these are your Hodgkin cells. Reed-Sternberg cells are like, one of these probably. And then you have a mixed population of like other cells. Like this kind of looks like a granulocyte. Or it could be an eosinophil. Like it just kind of look like there's a bunch of different cells here. I mean, I predominantly see lymphocytes everywhere, but it looks like there's other subtypes in here to the point where they can say it's mixed cellularity. And then there's lymphocyte poor. So lymphocyte poor, this is again your worst prognosis one. So here's your Reed-Sternberg cell right off the bat, but you don't really see other subtypes surrounding it. You see a lot of, actually it says you should see Hodgkin cells. This might be a Hodgkin cell here. But regardless, the primary thing around these cells is like, it looks like diffuse fibrosis. And again, it's just like not a good prognosis for this patient. And then little to no lymphocytes, obviously in the name, lymphocyte poor. Okay, non-Hodgkin's lymphoma. This is going to be linear, meaning it's not bimodal. So the increase in the disease is going to increase with the age. So remember with Hodgkin's, it's like usually people between the ages of like 15 and 30, or is it 15 and 35? I don't know, but it's like when you're 15, you're likely to get it, and then when you're 30, you're likely to get it, or 35, you're likely to get it. It's really weird. It has that bimodal frequency. This is linear. So this is like when people typically think of cancers, they typically think of like older people, something wrong with mismatch repair, or like something happened in the body and now cancer developed. That's non-Hodgkin's lymphoma. It's called linear. So as you get older, the likelihood that you're going to get it is going to be increased. This is a non-contagious spread of the disease. So basically what this means is the cancerous lymph nodes are not next to each other. Hodgkin's lymphoma, they are, and that's why the clinical staging is like a lymph node region. They take a whole region and they stage that stage 1. Then they take 2 regions, that's stage 2. You can't do that with non-Hodgkin's lymphoma because it could be like the lymph nodes might not be next to each other. And then nodal and often extranodal, using any organ, can be involved here. So remember, the stomach's the most common extranodal location, but it can be any organ with non-Hodgkin's lymphoma. Actually, someone I know that had non-Hodgkin's lymphoma, their stomach was involved, but it could be honestly any organ. And then for this, I would say for non-Hodgkin's lymphomas, know is it a B or T cell lymphoma? B cell, way more common than T cell. So B cells like 70%, T cells 30%. Know your classic patient population, know your translocations and mutations, and any buzzwords. And like I said, I try to point them out as we go. There's a lot more of the non-Hodgkin's than the Hodgkin's. So first, we're going to start with B cell non-Hodgkin's lymphoma, follicular. Okay, which hopefully is intuitive that it's a B cell non-Hodgkin's lymphoma because B cells have follicles, so hopefully that helps. But your classic patient population here is going to be adults. The translocation is 14-18. So the translocation for 14, so chromosome 14 is where the immunoglobulin heavy chain location is, and chromosome 18 is BCL2. So what's interesting is these are B cells, right? So imagine B cells, they're always churning out heavy chains, right? Like I said, they're always making antibodies. So they're turning out heavy chains, they're turning out light chains, they're making antibodies. So think of this as the Ig heavy chains are always being made in normal B cells. Now all of a sudden you have a translocation. So now it basically switches. So now BCL2, which is an anti-apoptosis gene, so it stops apoptosis. And remember, apoptosis can be good. We want cells to die when their time has come. So this now, BCL2 stops that process. Now imagine BCL2 being in the location where the heavy chain is supposed to be. The body thinks it's making heavy chain, and actually it's making BCL2. It's making way, way, way more BCL2. So that's what happens you'll notice with a lot of these B cell non-Hodgkin's lymphoma, a lot of the times it's a translocation of some sort with chromosome 14. Not all the time, but some of them do involve chromosome 14, and it's overexpression of the other, whatever it's translocating with. So the result here is going to be overexpression of BCL2. So you are not going to get apoptosis. But what BCL2 does is it hyperstabilizes the cell membrane. I always get this question. How does hyperstabilizing the cell membrane lead to no apoptosis? That makes absolutely no sense. But the reason why is because for apoptosis, you need to be able to break apart the membrane so that the cell can die. Here, you're not allowing the membrane to break apart, so you can't have apoptosis to occur. So now these cancerous cells can escape cell death, aka apoptosis. A buzzword to look for here is look for a waxing and waning lymphadenopathy. And I believe the reason for this is because the Ig heavy chains are not constantly being produced. So it's they're being produced all of a sudden, then they stop, and then they're being produced all of a sudden, then they stop. So when the translocation occurs, this overexpression of BCL2 occurs, and it stops, and it occurs. So that's kind of like the waxing and the waning. It gets better, and then it gets worse, then it gets better, and then it gets worse. This is from first aid. I wanted to show you where BCL2 is in this process. So with apoptosis, there's two things. There's Bax and BAC. These are pro-apoptotic factors. They promote apoptosis. And then there's BCL2. BCL2 stops apoptosis from happening, and it's stable. It basically hyperstabilizes whatever membrane is here. So here, it's hyperstabilizing the membrane. It's not allowing the cell to die, and that's why these cells are able to escape cell death, essentially. Next, we're going to have a B-cell lymphoma called mantle cell lymphoma. The classic patient population here are adult males. So here you go, mantle cell and males. Yeah. All right. And then here, it's going to be a T1114, so a translocation of chromosome 11 and chromosome 14. Look, chromosome 14 is back. We know that. We know what that does. That's Ig heavy chain, so we know that this is being produced. So we know this cancer is going to be an overproduction of whatever is on chromosome 11. Chromosome 11 is cyclin D1. Cyclin D1 is a proto-oncogene, and if you guys can remember from cell cycle stuff, cyclins regulate the cell cycle. They basically help or they help the cell cycle in some way. So we're overproducing cyclin D1. Cyclin D1 is a proto-oncogene. Proto-oncogenes stimulate growth. I actually talk about proto-oncogenes versus tumor suppressors, I think, in the next session next week. So I'll talk about that difference between proto-oncogenes and tumor suppressors. But usually proto-oncogenes promote growth. They're normal. They are normal. We all have proto-oncogenes. They're normal. We need them for growth. But now we have too much of it. We have way too much of it. Now it transformed to just a straight-on oncogene. Now it's bad. It's cancer producing. So that's because of this translocation, this 1114 from mantle cell. So my buzzword or note here is they'll probably point to a section of a lymph node, and then you need to know that that's the mantle zone. Or they'll say expansion of the region immediately next to the follicle. So rather than pointing to the mantle zone, they'll just say there's an expansion of a region immediately next to a follicle. So they're kind of getting back to lymph node anatomy. Okay, so I'll show you that, but I want to quickly tell you about marginal cell because it's the same idea. So marginal cell lymphoma, this is also a B-cell lymphoma. Classic population here is adults. The translocation, it's actually not involved with chromosome 14, whoa, but it is two that we already talked about. So this is a translocation of 11 and 18. Chromosome 11 is cyclin D1, it's that proto-oncogene we talked about, and then chromosome 18 is BCL2, so it's that anti-apoptotic factor. And then buzzwords and notes here, you tend to see marginal cell lymphoma in patients that have chronic inflammation. Hopefully that makes sense because B cells, when their follicles get stimulated to get activated, essentially, right? When you have follicular hyperplasia and whatnot, you're going to get expansion within the follicle. So the marginal zone, the mantle zone, whatever. So a marginal cell lymphoma, you tend to see it in patients that have chronic inflammation. This is what I was trying to say before I just didn't look down and read. But a marginal zone only forms when a germinal center is created. That's what, I forgot what the heck a germinal center was for a second. I said follicle instead. I meant to say germinal center. Remember, a germinal cell is only, a germinal center is only created once B cells have been activated. And then once you have a germinal center, now there's a marginal zone separating the germinal center basically from the rest of the follicle. So that's why you tend to see this type of cancer with chronic inflammation. You need a marginal zone. So you need germinal centers, right? So if you see a marginal cell lymphoma in like an extranodal site, right? So like, let's say now it's in like a mucosal site, like the stomach, even Peyer's patches, just like outside of a lymph node, but still in like a mucosal site. That's called a maltoma, a maltoma. Okay. It's like a cancer of the mucosal tissue, essentially, but it's still a marginal cell B cell non-Hodgkin's lymphoma. All right, so this is back from immuno. Remember, here is a lymph node, and we have our germinal center in the middle, then we have our mantle zone, and then we have our marginal zone. And remember, they only really develop once you have those germinal centers that form. If they want to be, cheeky and show you a histo slide, because why not? We're second year, right? So all path all the time. Here's the germinal center, the mantle zone is right next to it, and then you have your marginal zone immediately next to that. Okay, next is diffuse large B-cell lymphoma. So we did talk about this. This was like the Richter transformation we talked about. So we're going to talk about that again. Diffuse large B-cell, I know this is really weird looking, but I'm going to just explain it really fast. So the classic population here are older adults. This is going to be BCL2 overexpression or BCL6. And remember, BCL2 is your anti-apoptotic factor. It hyperstabilizes the cell membrane. No apoptosis. Now these cells can escape cell death. So this is not a translocation. So diffuse large B-cell lymphoma, and sometimes it's abbreviated diffuse large B-cell lymphoma, like that, DLBCL. This is not a translocation. This is just BCL2 is overexpressed in this patient. There's just more BCL2 now in this patient, or BCL6, but they kind of do the same thing. They both are involved with hyperstabilization of the membrane. Buzzwords or notes, really no buzzwords, but this is the most common type of non-Hodgkin's lymphoma. And you kind of see here, this is kind of showing you like the process, like it's kind of like a TBT to immuno with the VDJ rearrangement. Now we're in a lymph node. Here's your germinal center. Here's your mantle zone. Here's your marginal zone. And then it's kind of showing like, here's your BCL6. Here's your BCL2. There's really nothing to get from this picture. I just wanted to remind you of the like a lymph node again. But yeah, we'll talk about it again with the Richter transformation. I do bring it up. I don't know why I didn't put it right after that, but it's coming up. Next, we have another B-cell lymphoma. It's called Burkitt's lymphoma. This is the most aggressive. I don't know if this was a quote from Sitar or just me. Maybe this is me just saying the most aggressive. I'm pretty sure Sitar says it. But this is a very, very aggressive B-cell lymphoma. The population are young adults, but it can be kids. Like young adults is so like generic. It could be like a 14-year-old is like a young adult, or like a 12-year-old is a young adult. But regardless, it can even be like a 17-year-old. So again, age is always like, But regardless, this is a translocation of chromosome 8 and 14. 14's back. We love it. We know what that does. So this is your IG heavy chain. So we know whatever's on chromosome 8 is going to be overexpressed. In this instance, it's c-Myc. c-Myc is like classic proto-oncogene. And again, proto-oncogenes are really good for stimulating cell growth and development. So if we have an increase in it, now it basically is like it doesn't stop cell growth, and that's how you get your cancer. And again, like I said, we'll talk about proto-oncogenes in like the session next week. And then lastly, we have our buzzwords and notes. So look for like starry sky appearance, tingible body macrophages. So starry sky appearance, I guess like they'll just say that. Actually, I think that, let me go back to the very first slide. Yeah, this one. They actually put the Burkitt's lymphoma background to starry sky just to be funny. But I mean, I guess it's starry sky. I don't really know. I mean, fine. But like if they say that terminology, it could be Burkitt's lymphoma. So sure, this could look like a starry sky appearance. These are tangible body macrophages, these like big guys, and you saw them in the other one with the Van Gogh picture. These are basically just like activated macrophages. That's all tangible body macrophages are. They're just activated macrophages. Epstein-Barr virus is involved with this, so EBV. Jaw swelling in an African child, that always comes up. That's why I was like 8-year-old African boy with blank, and it was like Burkitt's lymphoma. That's like very like buzzwordy for this one. And then you can also get abdominal involvement in the sporadic form of Burkitt's rather than the jaw. So jaw is usually in the African boys, and then the abdomen is usually in the sporadic form, the one that kind of just like comes out of nowhere. We have Sézary syndrome. So Sézary syndrome, this is your first T cell one that we saw. Like I said, it's 70-30 with the B cells. But so this is Sézary syndrome. Sézary syndrome is usually in adults. This is a form of cancer that develops from mycosis fungoides. And mycosis fungoides is basically a infection. It's an infection that you can develop where that infection can lead to Sézary syndrome. So mycosis fungoides is a skin infection. It's where you have neoplastic, so cancerous T cells, and they are CD4 positive T cells, so these are helper T cells. Cancerous helper T cells proliferate, and then they get into the skin, okay? Those skin plaques, if you were to like biopsy them, it shows these aggregates of cancerous cells, okay? Sometimes they'll show you, so like here's like what those like skin plaques can look like in this picture here. And sometimes I don't know how to pronounce this word. I actually meant to look it up before right now, but here we are. So Potrier microabscesses. But this is like, if they don't show you a picture or they don't say, you know, there's skin plaques, they might try to be like fancy and call these Potrier microabscesses. Whatever, but they're the same thing. They're abscesses on the skin. I don't really know what Potrier means. I might look at, if I remember, I'll look it up and put it in like the little notes at the bottom. Okay, but this is what it looks like. You have all these skin plaques just like everywhere, and then you take a biopsy of it, and then it's like a bunch of neoplastic cells everywhere. Those are neoplastic T cells. From here, so that's mycosis fungoides. So that is what mycosis fungoides is. From here, it can develop into Sézary syndrome, and Sézary syndrome, this is like more of the cancer, like that's asked about. So Sézary syndrome is when those neoplastic T cells get into the blood. So now this bottom picture, this is a peripheral blood smear, and we have a weird ass looking cell here. You're like, is that a blast? Is that a monocyte? What the heck is that? These are called Sézary cells. And again, it's probably a guy that discovered this. He wanted to name it after himself. But a Sézary cell is basically this neoplastic T cell, this neoplastic CD4 positive T cell, and they call it that it has cerebriform nuclei. So I don't really know how much this looks cerebriform, but whenever you see this term cerebriform nuclei, they're trying to say it's like not like colored in all the way, so to speak. So it's like this. First of all, it's weirdly shapen. So this nuclei here is like shaped like a, this honestly looks like that star from SpongeBob, you know, and it's like the background of SpongeBob, how they have like the stars. Yeah, the flower, sea stars, whatever. It kind of looks like that. So it's a weird shape, first of all. But then it's like, see how it's like not completely filled in all the way? Like where some nuclei are like dark. This is not helpful. If I go back to, oh my God, bear with me. That's also not white blood cells. All right. So see how like the nuclei is like very like uniform. These are also cancer cells. So this is not helpful. But like just in general, just imagine like a nucleus. It's usually like homogeneous. Usually it's supposed to be homogeneous. With Sézary syndrome, the nucleus is like, it has like some areas of white. Like it's not completely uniform in how it's drawn or how it's colored in. That's a Sézary cell. It'll be obvious that this is Sézary syndrome if they talk about, you know, something skin-wise and then they show you a picture, or they call it like a cell with cerebriform nuclei. That's your buzzword for Sézary syndrome. And it comes from mycosis fungoides. You'll cover mycosis fungoides again in the skin, in Pathoma's skin chapter. Okay, small lymphocytic lymphoma. Again, don't know why I didn't put, you know, this right after the diffuse large B-cell lymphoma, but regardless, remember that, so this is now chronic lymphocytic leukemia, CLL. When it's in the blood, it's called CLL. SLL is if the CLL gets to the lymph nodes, and now we have a lymphocytic leukemia from the lymph node. It's the same thing. It's the monocyte macrophage thing. So the World Health Organization deems them one entity, different clinical presentations based on where like the site of involvement is. If it's in the blood and the bone marrow, that's CLL. If it's in the lymph nodes and the lymphoid organs, that's SLL. But it's the same. So for example, here's a slide. I see basophilia, not basophilia. I see lymphocytosis. Oh my God, it's late. I'm sorry. I see lymphocytosis. I see tons of lymphocytes, and then I see smudge cells. These are like my keys. This is key for CLL. This patient's probably like 65 years old. And then they show you this blood smear. I see tons of lymphocytes everywhere. I see smudge cells. I see splenomegaly, I see hemolytic anemia, I see other B symptoms. I'm very confident it's CLL. Then all of a sudden they're like, oh, this biopsy was actually taken from the stomach. Or no, that's literally not. Taken from a lymph node. I'd be like, whoa, but I'm pretty sure this is CLL. It's just not called CLL now. Now it's called SLL, but it's a CLL. It's like the same thing. Everything else is like the exact same about CLL. So just like CLL, smudge cells are diagnostic. And then you can undergo the Richter transformation, which we already talked about. But the Richter transformation is basically when you have CLL, aka SLL, just you have one of these two transforming into a super aggressive diffuse large B-cell lymphoma. That's called the Richter transformation. There's nothing really else special about it. It's just, remember, then they could ask, what's the mechanism of diffuse large B-cell lymphoma? That's your BCL2 or BCL6 overexpression. So you don't allow for apoptosis to occur. Okay, that was everything. We got through it all. But I will upload this and do the questions and let me know if you guys have any questions about the questions. I'd be happy to answer them. All right, bye guys.